Is there a difference? What is the difference? The base of most IRBs uses this as the definition. So just look at that for a second. Clear intent before treating the patient to use systematically collected data. I want you to chew on that for a second. We'll circle back in a minute. So the levels of evidence, we all know these well, and this is how we progress from an idea to an accepted standard. Typically somebody gets an idea, then they describe a case, or they do a couple cases. Those case series become larger, sometimes with cohort comparisons, and then finally on to trials, and then we move to standard of care. That didn't happen with laparoscopy. Now, laparoscopy is the backbone of IPEG, but with the big cases, cholecystectomy, splenectomy, nephrectomy, adrenalectomy, I would add proctectomy. In others, there was no question that as soon as the case series came out and there was small cohort series, that there was no way you could compare the two, because you could do the same operation, accomplish the same goals without doing a laparotomy, and that translated into all downhill benefits for the patient. That was a disruptive innovation. Like the automobile, like PCs, Netflix, smartphones, we probably don't need a randomized trial to tell us that our smartphone's better than carrying around the 23 devices that it replaces. So with laparoscopy, it went from an idea, a couple cases, a couple more cases, and then bam, straight to standard of care. So what's the problem? The answer is there's not, as long as you're right. And so if it is the automobile, if it is the smartphone, and no one's ever been doing a laparoscopic proctectomy and thought, geez, wasn't that great when we used to stand on our heads and try to find the lateral stalks? Everything's been better, but we're not always right. And so that's why sometimes we have to be cognizant of moving to the next levels of evidence before accepting a standard. Otherwise, we fall victim to performing subconscious maleficence. And what's that? Not her. It's worth seeing, though. It's him. So it became a common standard to treat mental illness with penetrating cerebral trauma. That's a frontal lobotomy. That's a position that you don't want to find yourself in. Multiple examples, there's some spectacular ones where after showing feasibility in dogs, it became a common treatment to treat a stroke with an extra to intracranial artery bypass. And then after many, many patients were treated, a randomized trial was done, and then the operation went away. Based on case series and cohort studies, joint debridement became one of the most common operations done in the mid-1990s for osteoarthritis. And only after millions of patients were treated was a randomized trial done against a placebo and found no benefit. We know many other examples of subconscious maleficence. I'm sure if you sit and think about it, you can think of multiple examples that aren't on this list, but the jejunal-ileal bypass for obesity, just a couple decades ago, it was standard to yank out a spleen for a blunt trauma, and now that's never done. Remember Swan-Ganz catheters? When I was a second-year resident, it's not that long ago, maybe it is, you went and got the Swan numbers on every patient that was in the ICU, every day. And I don't think it helped any of those patients, and now we know that. But it became a standard before it got compared to having non-invasive monitoring. So for the residents and the med students out there, this slide's for you. Listen to us, learn from us, but think for yourself and keep a critical eye open. The people at the back may not be able to read the bottom there. It says, just because you've always done it that way doesn't mean it's not incredibly stupid. No insult to the Spanish. So how do we prevent from becoming tomorrow's example? By getting comparative data early. And yeah, right, it's that easy. No, it's not that easy. You know, just swing, hit it, it's right there. It's not that big of a deal. But it does take an effort, and it takes an effort to overcome the natural way that we think as physicians and as people. Because when we talk about trying to get equal evidence between two groups, there's this assumption that it requires equipoise, initially defined by Charles Fried as a condition in which the physician is truly indifferent between the therapeutic value of an experiment versus a control. Now we know that that's almost impossible. Just the slightest little bit of evidence is going to lead people to a certain practice. Everybody in this room has a way of practicing. There could be many of things that led to that practice. But either way, now that's the way you do it. And pretty much everybody here practices medicine the right way. even though they may be very different. But in our minds, that's where we go. And it's been the assumption that in order to have comparative data or to do a trial, we need to have equipoise, but I don't think that's true. I don't think personal equipoise is necessary. I don't even think personal equipoise is possible. I think no matter how 50-50 you think you are on a game that's about to be played, you'd be willing to make a bet. No difference than if you had to take a choice between two procedures. I think you'd be willing to make a bet which one's better. And in some cases, it can be quite clear in your mind. But that's okay as long as there's enough evidence to support both arms. So I'll give you an example in our hospital. I think most people know the study but may not know the story. Our interventional radiologists were convinced that fibrinolysis to treat empyema was just as good as VATS. Now we, on the other hand, in surgery, knew for sure that thoracoscopy was better. We knew that for a fact. So why would we bother doing a trial when both groups know that they're right? Well, both camps can acknowledge that there's no comparative data and all of our assumptions require proof, and so we just design a trial that has a fixed management that nobody can influence from either side of the fence, and we see what happens. We included these patients, and this is why we surgeons never thought in a million years that fibrinolysis could be beneficial. We used a 12 French chest tube with 3 rounds of TPA compared to VATS, and what we found was shocking. So, as a primary investigator going into this study, totally convinced that VATS was better, retrospective data that showed VATS was better by 2 days. We were almost finished with the study, and Chuck Lies, I see, was the fellow, and he said, if your daughter came in with an empyema, what would you do? And I said, I would just do the TPA, because none of those kids get sicker. Hadn't even seen the data yet, but when they were both managed on our service in real time, it was a shocking eye-opener for all of us in surgery who were totally convinced that VATS was the only way to treat these patients. And what we found was that there was no difference in recovery, but it cost more. So at the same time, a trial came out from London that said the same thing, and so we moved on with our fibrinolysis protocol. Not here to debate about empyema within your hospital system, whatever works for you, the outcomes are equivalent. But in our hospital, it made a universal change. We went from having a contentious consult between the PICU, the PEDS team, ID, interventional, and surgery, to now having one way of managing all these patients, no discussion, they just roll downhill. And we treated the next 100 patients and found the same results as we found in our 18 observations from the trial, except that we were actually doing a little bit better. So now at the end of the day, we went from having a house divided at a contentious consult to our interventional radiologists are happy because they were right. Our surgeons are happy because now we know we have a smarter way of treating all of our patients. And we got there with data. So if we see that we can progress care with data, then let's go back to addressing this issue of innovative treatment, or is it research? Systematically collected data that would not ordinarily be collected in the course of clinical practice. I think that sounds pretty good. So why not do both? They can overlap, and I think in a lot of cases they should overlap, particularly when we're talking about innovations and new techniques and new ways of managing patients start to replace old techniques. We have to be aware of these moves, because particularly if we're adding layers of expense, like with the Swan-Ganz catheter, we want to be able to carefully make sure that we're actually seeing a benefit at the end of the day before that just becomes the replacement. And in an example that happened in our hospital, and many of you may be familiar with this as I presented it last year at IPEG, but where it started, you didn't hear the background story, which is that our interventional radiologists were starting to use TPA in abdominal abscesses. And so we were just off the back of the fibrinolysis trial. TPA was the answer, so they were putting it in the abdominal abscesses. And we thought it'd be important, both surgery and intervention. We do that, it's not TPA that's going to go away, it's the saline that's going to go away. What'll happen is we'll just start doing it, we'll get enthusiastic about it, the saline will go away. It's a complex, evolving system, the way that we're treating abscesses. We'll be comparing our new experience against our old experience, which is completely invalid because we're using drains differently, we're changing our antibiotics, we're getting people out of the hospital sooner, and so everything's evolving at the same time, and we will have lost the window to make a difference. So fortunately, they agreed. We carried on with the study, and the study was designed around the fibrinolysis decreasing length of stay by a day. It turned out that it increased length of stay by a day. So there was no difference except that there was an increased length of stay from using the TPA, and there was no difference in the downstream effects except for it was more expensive. So it was more expensive, more risky, and it didn't help the patients. So in the system that we were looking at, we ended up instead going from a new therapy, comparing it to the standard. It produced a worse outcome, and so now our standard remains. So that was sort of a near miss, and that's an example of using data to try to prevent just diving into a new therapy. So if we're going to do that, if we're going to evaluate a new therapy against a established cohort, then how do we go about doing that? And the two things I'm going to address is getting the population of people to participate in the study, and then the data points to look at. And as far as establishing the people, it's important to get a group of people who are invested, interested. They don't have to have equipoise, they just have to be fair. They're going to play by the game, do the best they can, no matter what the randomization card pulls up, then you just do the best you can, and that's that. And it has to be a fair real-time comparison, because even if they've done a bunch of 3-ports, let's say, they're still going to be getting better. And if they've done a bunch of stills, they're still going to be getting better. So the comparison at the same time is also probably important. And I'll give an example of where we saw that in our single-site versus standard 4-port laparoscopic cholecystectomy trial. We saw this difference in op time, which we reported, and that's known. But the story is a bit more complex than that, because when you look at the patients, I mean the surgeons individually, these are the average times of the two groups for each individual surgeon. So if we were to do a case series or a cohort study within our own hospital, if we had the same thing going on and then we did a retrospective study, we could easily say surgeons 5 and 6, we compared their single site compared to the standard 4-port against the rest of the group, and make the conclusion that you can do a single site operation for a cholecystectomy just as fast, if not faster, than you can do a 4-port, even though surgeon 5 and 6 were no closer to their times than everybody else. So everybody in the group was not within 10 minutes of their own single site time, even though some of the single site times were much faster than some of the other 4-port times. And so that's the importance of real-time comparison. After our study, then there's been many more done, and that has been a universal finding, so that is true in that circumstance. Another thing to consider is what data points are we going to look for? And we're in a fortunate position that I think the days of the things that we're going to be studying in IPEG and in minimally invasive surgery, hopefully there won't be any conversations about mortality. There won't be any studies looking at a difference there, except for maybe something like biliary atresia. But that would obviously be the first thing you look at, and then you move down to major complications. And then from there, length of stay, degree of invasiveness, then minor complications, then treatment time, costs, charges, then convalescence, then cosmesis. And with advances like single site, we get down to where there's not a difference in any of these other things, so then we take a look at cosmesis, and if all of those things are equal, then we need to ask ourselves, what about the patient and the parent's overall experience? Like, how do they feel about the whole thing? So when we looked at early operation versus delayed operation for kids who present with an abscess, we didn't find any difference in any objective outcomes. But when we looked at how the families handled going home with a PICC line and waiting 12 weeks before their operation, they didn't do very well. They didn't cope very well. So then all of a sudden, even though that was down at the bottom of the list, objectively, you can treat a patient just fine by doing an interval appendectomy, but not all families are prepared to cope with that stress. So here's the punchline, is the overall theory of everything in assessing the clinical value with research. What you do is you take the length of stay multiplied by complications. That's over the top of the product of op time times cost. You take the square root of the convalescence constant times cosmesis. That's going to give you your treatment score. Once you have that treatment score, somebody's busted me. Once you have that treatment score, then you multiply that by the surgeon's comfort, 1 to 9, and because if you haven't done one of the therapies, then it wouldn't count. And then that's what you offer the patient. And of course, that's never going to happen. So regardless of everything we just talked about, there isn't a superior way. There isn't a way to say this is clearly the right answer. Sometimes a trial will give you that answer, but really what it gives you is data. And the data is important to know what are the differences in every little parameter, and how important are those parameters to all three people in the conversation, the parent, the child, the surgeon. And then once you have that conversation, then you can make an informed decision. Thank you.
Well, Sean, I think you nicely set the stage for David to break down the informed consent.